Everyone's doing. My name's Kelsey Ufholz. I am a research scientist at Case Western Reserve University's School of Family Medicine and Community Health, and I'll be sitting in the interviewer chair today. Dr. Goutham Rao, who is the director of the UH Advanced Center, and I shall be having a discussion on hypertension in the pediatric population. Good morning, Dr. Rao.
Good morning, Kelsey, and thanks for playing host this morning. Hope everyone's doing well.
No problem at all. So, to start off, can you tell us a bit about how you became interested in pediatric hypertension?
Sure. So I became interested around 2004. I was the clinical director of the Weight Management and Wellness Center at Children's Hospital of Pittsburgh. And around that time, the AAP, the American Academy of Pediatrics, had released their fourth version of their guidelines, the fourth panel or expert committee guidelines. And they included some very awkward, very dense tables that they included in the journal Pediatrics. Were very difficult to use. So I was working with a med student who wanted to do a research project, and I said, well, why don't you apply these tables to some of the patients in our primary care general academic pediatrics division to see how we're doing in terms of diagnosis of hypertension. And this was nearly a year after the guidelines had been released. And then he started to come back to me with some pretty surprising results that almost none of the children whose blood pressure qualified them for a diagnosis had been diagnosed at all. So I realized that we had a very significant problem. And that's really what spurred my interest in improving diagnosis, and not just improving diagnosis, but looking at some of the consequences of this condition.
Thank you. You mentioned the guidelines a few minutes ago. Mm-hmm. Can you say a little bit about those and how pediatric hypertension is defined?
Yeah, that's a good question. So whenever we define something based on numbers, there's something called a reference standard and a criterion standard. So the classic 140/90, which was the standard for diagnosis of hypertension in adults for many, many years, is called a reference standard. It is simply the 95th percentile of systolic and diastolic blood pressure in the population. So the standards we have for pediatric hypertension are also reference standards. They are the 95th percentile for systolic and diastolic blood pressure in children. The challenge, Kelsey, is that children are different. They're growing and they're developing. Boys and girls are different, and children of different height percentiles are different. So the standards are, you can't use just one number, though we have one number for adolescents now. You have to adjust numbers for younger children, for sex, for age, and for height percentile. Now, for adolescents, the situation is much simpler. The 95th, well, the threshold for hypertension is simply 130/80, which is what it is in adults as well. So it's relatively straightforward. But that's a relatively recent development. The standards were very complex, obviously, prior to that.
Mm-hmm. Yes, this sounds like a complicated topic, especially for diagnosis purposes. So, having hypertension at such a young age, what sort of consequences are these kids looking at?
Yeah, I mean, there's this perception that this is a relatively rare problem, which it's not. Let me address that issue first of all. So the newest guidelines for hypertension in children and adolescents are based upon children who do not have overweight or obesity. And those are risk factors for high blood pressure. So it's normal weight children. And when people have applied the new standards to children across the American population, we wind up with a prevalence of roughly 5.5%, or more than 1 out of every 20 children, which is quite common. Not nearly as common as it is among adults, but still quite a common problem. Now, I think you can divide the consequences into two categories. One is what happens within childhood and adolescence, and then what are the long-term consequences of hypertension in children. Even within childhood, we know that children who have blood pressure in the hypertensive range are likely to have something called increased carotid intima media thickness. So, hypertrophy of the carotid intima in the neck. And that's a sign, that's a strong indicator of future atherosclerotic disease as well. So it's an intermediate outcome because it's hard to get long-term outcomes on these children, but it's a significant indicator. We also know that children, even within childhood, can have microalbuminuria, protein in the urine. And we also know that a significant proportion, perhaps 10 to 15%, have significant left ventricular hypertrophy. So that's all just within childhood itself. So you see that, the adolescent child who has hypertension, they're much more likely to have these problems. Then there's the whole category of what happens to these children as they grow up. We know that they have about 2 to 3-fold risk of having hypertension as adults, and many of them will have the consequences as well. We know that blood pressure in childhood is associated with the level of carotid intima media thickness in adulthood as well. So it all starts quite early. It makes absolutely no sense for us to start detecting and addressing hypertension only in adults when the problem starts far, far earlier than that.
Yes, indeed. The earlier you can intervene on this, the better the outcomes.
Certainly.
So are there some children that are more likely to experience hypertension than others?
Yeah, so that's certainly true. It's the usual indicators, I think, people who have children who have a family history of hypertension. Of course, there's a whole cause, much less common secondary hypertension. They may have some underlying diseases. But looking at a population standpoint, it's much more common in boys than in girls. And it's interesting, Kelsey, we don't have great prevalence estimates across the population. And it's because it's for a number of reasons. First of all, diagnosis can be challenging. It requires multiple readings over several office visits. But it's fair to say that about 60 to 65% of children with hypertension are boys. Certain racial and minority groups are disproportionately affected. We found this during my work in Chicago. African-American children are much more likely to be affected. And African-American boys in the adolescence range are much more likely to be affected as well. In fact, there are some estimates that about 10 to 15% of African-American adolescent boys might have hypertension, as we'll talk about in a moment, that's a serious problem because a lot of them are not detected.
So it sounds like diagnosis is a lengthy and complicated process. Can you describe that a bit more?
Yeah, so it is. And so I gave you the threshold blood pressures, but it's not good enough to have a child come into the office for one blood pressure reading. The guidelines require us to have 3 readings on 3 separate days that are averaged together. And then whichever puts you in the higher blood pressure category, systolic or diastolic, is the type of hypertension you have. Now, we have not done well in terms of diagnosis. Let me give you some historical consequence. I talked about the 4th expert report on hypertension from 2004. The first report was published in 1977, so 46 years ago. And in that report, it states quite clearly, blood pressure in children is the next frontier. And it's remarkable how little progress we've made in 46 years. In that report itself, it recommended measuring blood pressure in children annually, beginning at age 3. Now, I had the privilege of serving on the National Quality Forum's Child Health Steering Committee in 2008 to 2010, something like that, where we actually looked at making annual blood pressure measurement in children a quality standard, and that was successfully completed. And for the most part, children in primary care do have their blood pressure measured. It's about 60 to 70% at least annually. So, but that doesn't solve the greater problem that we're missing diagnoses of hypertension, and that's consistent. About 3/4 of cases have been missed. The reasons are complicated. Of course, there's a complicated standard for diagnosis, especially in children under 13. It's failure to integrate prior blood pressure values into the current visit. as well. So in adults, we have a simple threshold. Oh, you're hypertensive as well. It's fairly straightforward. There is a lot of problems with measurement. I've spent many hours observing medical assistants and nursing staff taking blood pressure in kids, and it's much more challenging than it is in adults, especially with the really young kids. They have to be calm and seated and for 10 minutes at a time. Not something that's easy to do. So all of those things, I think, contribute to very, very high rates of misdiagnosis. We do have some tools. So as you know, here at university hospitals, we are embarking on implementation of the EPIC electronic health system. So I'll throw this out there for those who are listening. But if you are wondering about a child's blood pressure, type in the smart phrase .bpfal. That's blood pressure for age and length. That's what FAL, no spaces there at all. And it will give you the child's blood pressure percentile and the thresholds that define hypertension for that particular child, assuming you have a height, age, and the sex recorded in the electronic health record. So very, very poor rates of diagnosis, unfortunately, overall.
Yes, 3/4 of cases being missed. That is certainly a very high rate of misdiagnoses. And you mentioned that the causes are things such as the child has to be calm, repeated measurements, etc. Are there any other causes that?
Yeah, it's interesting. So we did a study in Chicago, 2013 to 2016, in a network of federally qualified health centers that care for children and adults. And we enrolled practices that employed both family medicine physicians and primary care pediatricians and APPs in those with training in those specific areas. And we found that through clinical decision support, for example, giving you the smart phrase that I just spoke to you about, education through something called an ECHO program, through guideline dissemination, through training of nursing staff, observation, correcting them, finding lead MAs in each practice who could review technique. We found that we were able to improve blood pressure diagnosis to a significant degree, not tremendously. It was like 8 to 10% improvement. So we went back to the providers afterwards and asked them, well, what do you think went wrong? We didn't do as well as we wanted to. We had some improvement, but this was a lot of work and effort for a relatively modest improvement. And they all said the same sort of thing. It's not necessarily us, it's the patients. It's very difficult to engage them. And the number one barrier they cited, Kelsey, was the need to return to the clinic for 2 additional blood pressure readings. So a child comes in, he or she is nervous, you get a reading that is well above the 95th percentile. Somebody says, well, you ought to come back on a separate day so we can get another blood pressure reading. And that does not happen quite often. The other barrier was very simple things. And I see a number of people from primary care on this call, but it's just the basic workflow that we had to work out. So for example, a child comes in, when is the blood pressure taken? Let's say they're there for a well child check, 10-year-old well child check. When do you take it? The MA takes the blood pressure. Now that blood pressure has to be repeated in the same visit to make sure it's to help rule out white coat hypertension, though it's not going to be completely effective. And so what often happens is that the pediatrician or family physician will go in and see the patient, and they'll notice the blood pressure is high, and they'll ask the MA to take the blood pressure again. Of course, by that point, the MA has moved on to a different task. It sometimes gets forgotten. So one of the ways around it was to give the MA thresholds themselves, depending on age, that they could use to carry as a card. It says, okay, just repeat the blood pressure if it's above these specific levels. So those kinds of issues, I think, were quite significant. So we started to think more about patient-centered approaches to improving.
Got it. So in the spirit of looking at patient-centered approaches, UH Advanced Center is about to undertake a project to measure adolescent blood pressure in the home environment. Mm-hmm. Can you say a bit more about that?
Yeah, I got interested in this about 4 or 5 years ago, as you know, So how do we overcome some of these patient-related barriers, specifically the need to come back? And imagine having to bring your child back to the office just to have a second or third blood pressure measurement. And these are typically kids who can't come on their own. Somebody's got to bring them there. Somebody's got to pick them up. It might be missing work or school. It's very inconvenient, first of all. So I know that in other countries, in Japan, where I have a colleague who is perhaps one of the leading experts in the world in this specific area, he could you please mute on the inpatient team, please? So he, in particular, has said in Japan, they do a lot of home blood pressure measurement, as well as a lot of nocturnal blood pressure measurement as well. So this, I think, overcomes some of those convenience barriers, but there's other benefits too. I think we know that a significant number of children who come in to the office will have white coat hypertension. So the blood pressure that is initially high is not substantiated by subsequent measurements. In the home environment, they're usually more comfortable and relaxed. And so there's that particular advantage there as well. And the other thing I think is that when you're in the home environment and the parent is applying the cuff, or if it's an adolescent, they're kind of doing this together, there is the element of a patient who is engaged in diagnosis. And that's a new trend. We want to make shared decisions, and diagnosis is a team-based effort, as you know. So it involves the patient, the parent, as well as the physician together in terms of the process. And that engagement allows them to be more conscious of their blood pressure, et cetera. So that's one of the big advantages as well. The biggest thing, of course, is that home blood pressure values are more strongly correlated to target organ damage, things like left ventricular hypertrophy, and they are more strongly correlated to 24-hour ambulatory blood pressure monitoring, which is the gold standard. So it's just better. They're just more accurate than they would be otherwise. So for all of those reasons, we are embarking on a study to implement a 3-day home blood pressure monitoring protocol in African American adolescent children, which I'll explain in a moment. So it's blood pressure in morning and evening rather, for 3 days. The devices, of course, will average these and store these values automatically. And we chose that specific population because we need to have a significant number of positives, of course, and that particular population is at higher risk. That's why we chose African American adolescents.
That sounds like a very promising project. Does anyone on the call have any questions about pediatric hypertension in general or about this project in particular?
There's a question from Eva Johnson here. What about involving the schools in repeat measurements? Yeah, great question, Eva. Been there, tried that. It's possible, I think. Again, these are all workflow issues. So send a letter home with mom or dad saying this child's blood pressure was high. Would you mind repeating it in the school environment to the school nurse? A possibility, because the child is there as well, and school nurses, of course, would be highly skilled, very more than capable. So something to think about, but it doesn't overcome some of the other barriers of white coat hypertension. The fact that I think in a school environment with a school doing with a school nurse doing a blood pressure, we may have the same anxiety and risk for white coat hypertension that we would have in an office setting as well. But that in terms of convenience, it may be more convenient to do it. School-based screening of hypertension hasn't been terribly successful. In other words, many schools do require growth parameters to be taken, I think, annually, height, weight, body mass index, but blood pressure hasn't been terribly successful. Any additional questions?
No. Either through the chat or hop off of mute if you have one.
So, any thoughts regarding what could be the pathophysiology of hypertension in kids? I mean, we know in adults that there might be some um, problems with the blood vessels, atherosclerosis, and stuff
Yeah.
from that sort. But in kids, if it's not a secondary high blood pressure, what other
Yeah.
cause it could be?
That's a good question. So, the question is, why do some children develop hypertension? Well, I think it's largely based on the same risk factors that we see in adulthood as well. Overweight and obesity is a significant risk factor in children and adolescents. So, that's why the reference standards have excluded overweight and obese children, because it was so much more common. Again, not reliable values. Elevated blood pressure, which is kind of pre-hypertension, probably is 20 to 30% of overweight or obese children. And of course, it's related to family history as well. If you have a parent who has hypertension, if you have two parents, you're going to more likely to have it. Hypertension there as well. Diet is probably certainly related to it in terms of salt intake as well is a significant problem. And then Dr. Saeed mentioned, the whole secondary causes as well. And risk factors for those, so repeated urinary tract infections, for example, might lead to some renal parenchymal disease and elevated blood pressure as a result of it. So not that different than in adults overall. Of course, there's a higher rate of secondary hypertension. And the whole movement, of course, and we've had guidelines for more than 10 years now, is to identify these cardiovascular risks in children early on. One of the things we didn't talk about is treatment. It's like, and this is a source of consternation for a lot of people. It's like, okay, I've made the diagnosis, whether it's through home blood pressure monitoring, the 24-hour ambulatory blood pressure monitoring, which is challenging because the devices are expensive and it's disruptive to sleep, et cetera, or if it's based on clinic management. What on earth do I do next? Well, first of all, you would start, as you would with an adult, with lifestyle changes. If the child has overweight or obesity, then you would recommend physical activity and dietary changes, reduction of salt intake. These are all important measures as well. Sometimes just the parent knowing, for example, that their child has a specific problem is able to stimulate some changes in lifestyle as well. Now, and then the question becomes, well, if that doesn't work after 6 months, the guidelines say consider medications, of course. Well, and that is something that's not, that many people are uncomfortable with. In family medicine, we're more comfortable with these medications than they are in primary care pediatrics because we use them for adults. But nevertheless, there's a lot of discomfort around medications. Should I refer them to nephrology? Should I be doing this myself? Well, I think that there's a few things to remember. These medications have been used in children safely for many, many, many years. And I think that they have a good track record. And interestingly, some of the ACE inhibitors, ramipril, for example, has been shown to help reverse left ventricular hypertrophy in children. So it has some significant benefits in that sense. But I think the bigger question is not what medication you use. It's like, how do I have that discussion with the parent? And I would say, let's, your child, your son's doing quite well. I know you're trying to implement some lifestyle changes. I'm going to have to prescribe medication, at least for a short term. But if he gets to a healthier weight, if there's some improvement in his blood pressure, we can stop it and see what happens to his blood pressure after that. So management is unfortunately remains a challenge, but it doesn't make any sense to me to wait till these kids turn 18 or 20 and then say, okay, well, now you're an adult, we can treat you. And what we found in Chicago was that a lot of these kids, disproportionately male, and as we all know, that they get out of adolescence and become young men, going to the doctor is a very, very low priority. It's only when that employee physical comes along at age 28 or 30 and whoever it's doing it says, gosh, did you know you have high blood pressure, that we start to think about treatment. And by that point, some damage has been done. So a couple other questions, Dr. Koopman-Gonzalez, are there any barriers to access to home blood pressure devices? Great question. They are now covered through durable equipment suppliers, through Medicaid as well. The other thing to remember is that these devices are extremely inexpensive. Most of them follow some decent protocols. You can get a validated home BP device in children for about $50 to $60. One of the things we have said in our adult echo series is that every adult with high blood pressure should have a home blood pressure device. It should be using it regularly. 2/3 of adults with high blood pressure already have a device at home. And given that family history is a significant risk factor, the child might already have access to a blood pressure cuff. You just need to buy a blood pressure machine. You just need to get a new pediatric cuff, and those aren't expensive at all. So the barriers are quite low, especially when you contrast it to coming back to the office several times. And that's a significant barrier and a significant expense to societally as well. Okay, I think we are good. Any additional questions before we wrap up?
I don't think so. I think you covered all the important points. Thanks for taking the time to talk with us.
Okay, thank you, Kelsey. Thanks, everyone. Have a wonderful day.
Mhm.